All right, let's go over the quiz for Pulmonary 1. First question, to which lymph nodes would cancer in each of the following areas most commonly metastasize? So stomach cancer goes to the celiac nodes. Cancer in the duodenum and the jejunum goes to the superior mesenteric nodes. Sigmoid colon goes to the inferior mesenteric nodes. The upper rectum goes to the perirectal nodes. The lower rectum, above the pectinate line, goes to the internal iliac nodes, and then below the pectinate line drains to the superficial inguinal nodes. Testicular cancer would go to the para-aortic lymph nodes, and the scrotum drains to the superficial inguinal nodes. Next, what's the classic triad of symptoms in multiple sclerosis? So the classic triad is Charcot's triad of scanning speech, intention tremor, and nystagmus. But also remember the other common presentations, including bowel and bladder incontinence, internuclear ophthalmoplegia, and optic neuritis. And the last question, which lysosomal storage disease matches each of the following statements? So characterized by the accumulation of GM2 ganglioside is Tay-Sachs disease, and associated with renal failure is Fabry disease. All right, let's get started with the lecture.
Hello everyone, welcome to our Step 1 video on lung anatomy and physiology. Okay guys, I know I've been talking a lot of smack with this intro beef with Dr. McGinnis, but now's my chance to let you guys know what's really happening around here at DIT. Everybody thinks Dr. McGinnis is a mild-mannered dork who knits cat sweaters. Wrong! Well, the cat sweater thing's probably true, but in fact, he's more of your Silence of the Lambs type of guy. You think I'm in a super fancy studio right now, sipping on mochachinos and having my makeup done by supermodels? Well, that's a trick question, because I don't need makeup. But no, I'm in McGinnis's basement. I've been down here for years making lecture videos for him. If I don't say high yield 3 times a lecture, I get the hose. Okay, so hit the comment button and type free Dr. Lewis and McGinnis knits cat sweaters. Oh, here he comes, here he comes. And for a very high yield lecture on respiratory anatomy, here we go. All right, so let's start with tracheoesophageal fistulas. So this is an abnormal connection between the esophagus and the trachea. Now the most common type is an esophageal atresia, and this is an 85% of the time you're going to see this. And this is where the esophagus ends in a blind pouch, and then the lower esophagus actually connects to the trachea. Now because of that connection, you expect to get air in the stomach, right? So on x-ray, you could expect to see air or a bubble located in the stomach. Now there are actually several types of TE fistulas, and we're going to go through these A through E. Now in these images, the dark red is the esophagus and the purple is actually the trachea. So the first one here, A. A is esophageal atresia without any fistula. So as you can see, the trachea just doesn't connect in the middle, but there are no connections to the trachea. B is where the upper esophagus connects to the trachea. C is where the lower esophagus connects to the trachea. Now this is the most common type of that esophageal atresia, and again we see that about 85% of the time. Now I would definitely know this one. D is where both upper and lower parts of the esophagus connect to the trachea. And then E is where a fistula but no esophageal atresia occurs. Now sometimes the E type is referred to as an H type, and that makes sense because if you look at that picture of it, it actually kind of looks like an H. Now you should probably be familiar with the different types of TE fistulas, but especially remember that type C, that 85% of the time type of fistula. That type C is the esophageal atresia with distal tracheoesophageal fistula, where the upper esophagus, again, ends in that blind pouch. You're much more likely to get a test question on that one. All right, so we just have a couple more things to talk about with the trachea before we move on to the diaphragm. Now the trachea is lined with ciliated columnar epithelium. Now one potential question you might get regarding this is what happens to the epithelium in smokers? Well, you get metaplasia. The columnar cells will actually transform into squamous epithelium. Now where else do we see metaplasia? Well, remember that we saw this in the distal esophagus when there is chronic reflux. We call this Barrett esophagus. But in that case, we actually saw the opposite change. In Barrett esophagus, we see a change from squamous epithelium to columnar epithelium with goblet cells. So try not to get that confused. In the trachea, we see metaplasia going from ciliated columnar epithelium to squamous epithelium. And why would this be significant? Well, without that cilia, you can't move mucus as effectively. Therefore, smokers can't mobilize their sputum, and then you can end up with a chronic bronchitis where they're constantly trying to cough up a lot of sputum. Also related to the topic of cilia is Cartaginer syndrome, also referred to as primary ciliary dyskinesia. This is where a patient has non-functional cilia. Now this includes the ciliated cells in the respiratory tract, in the sinuses, the eustachian tubes, the fallopian tubes, and even in the flagella of sperm. Therefore, these patients will have chronic infections due to poor mucus clearance. They will have infertility, and some might experience hearing loss as well. Now, the reason the cilia cannot move is because of dynein. So dynein is non-functional in these patients. The dynein arm defect, and dynein is also responsible for that kind of walking along the microtubule action. If they cannot do that, the cilia can't bend and move things in a particular direction. Now, the other strange thing about Cartaginer syndrome is about 50% of patients with Cartaginer will also have situs inversus. Remember that situs inversus is a complete reversal of the circulatory system and viscera. All right, let's move on to the diaphragm. So the diaphragm is a sheet of muscle that divides the thoracic cavity from the abdominal cavity. Now, most importantly, it allows us to breathe. Now, the diaphragm is formed from a number of composite parts in the embryo. Now, the most important is the septum transversum. Now, understanding the history of the formation of the diaphragm actually explains why the heart and the lungs and the liver and the gut and the neck and even the fascia all sort of resonate strongly and have connections to the diaphragm. Now, the septum transversum is a thick mass of cranial mesenchyme that gives rise to parts of the thoracic diaphragm and the anterior mesentery of the foregut in the adult. Now, after its descent, the septum transversum merges with the growing pleuroperitoneal membranes, the dorsal mesentery of the esophagus, and the growing muscles of the abdominal wall. So it acts as the kind of meeting place for the embryological development of these cavities. So what if you have a problem with the diaphragm? Well, you might get a hernia. So a diaphragmatic hernia occurs when abdominal structures enter the thorax. Now, this may occur in infants as a result of defective development of the pleuroperitoneal membrane. Now, a congenital diaphragmatic hernia can have some serious complications. Now that we have abdominal contents in the pleural cavity, there is compression of the organs, which can then lead to a lung hypoplasia. Now, these hernias often occur on the left side, and there's also an association with polyhydramnios as well. Now, severe hernias can present at birth in a patient with a flattened abdomen. You might also see some cyanosis and the inability to breathe. This can also be diagnosed later on in life. Now, the most common occurrence of this is the hiatal hernia, where the stomach herniates upward through the esophageal hiatus of the diaphragm. Now, a sliding hiatal hernia is the most common. The GE junction can be displaced and is often referred to as an hourglass stomach. There's also the paraesophageal hernia, where the fundus actually moves into the thorax, and the GE junction here is normal. So again, a sliding hernia is when the GE junction and the cardia of the stomach protrude through the esophageal hiatus, and then in that paraesophageal hernia, only the fundus herniates through the esophageal hiatus. Further along on the diaphragm here, so the diaphragm is innervated by the phrenic nerve. So C3, C4, C5, the famous mnemonic C3, 4, 5 keeps the diaphragm alive. That's the innervation there. Now, one important clinical note is that the growing diaphragm actually kind of drags the phrenic nerves down from the cervical region to the thoracic region. Therefore, irritation to the diaphragm frequently presents as neck or shoulder pain. Now, this is also why it's going to explain patients with gallbladder disease or maybe a splenic rupture will have referred pain to the shoulders. Now, the last bit about the diaphragm is what structures traverse the diaphragm. So structures that perforate the diaphragm. At T8, you see the IVC, the inferior vena cava, is going to go through it. At T10, your esophagus and vagus nerve are going to go through it. At T12, your aortic, thoracic duct, and azygos vein go through that. So we got a couple mnemonics. So the one mnemonic is at T12 or T12, you see red, white, and blue, and that's going to be red for aorta, a white for thoracic duct, and blue for azygos vein. So that's one mnemonic to remember what goes through T12. The other mnemonic is I ate 10 eggs at 12. So I, the IVC, ate at level 8. Then 10 is going to be at level 10 eggs, and that's going to help you remember esophagus and vagus. And that's going to be cranial nerve 10 as well. And then at, so that's going to be your aorta, your azygos, and then your thoracic duct at 12. So that's at the level of 12. So that's how you can use that mnemonic to learn where you're going to see these structures going through the diaphragm. Okay, so now to cement this in your minds, I want you to stop the video and take 30 seconds. I want you to write down the 4 embryologic structures that make up the diaphragm, and also write down what innervates the diaphragm. Okay, so remember, the 4 structures were the septum transversum, the pleuroperitoneal membranes, the dorsal mesentery of the esophagus, and the abdominal wall. And then what innervates it? Remember, it's that phrenic nerve. C3, 4, 5 innervates that diaphragm. If you didn't get those, then review it again. All right, so now we're moving on to the airway zone. So look at your respiratory tract in general, and you can actually see that it's divided into different areas, into areas where gas exchange is taking place, and then also in areas where gas exchange is not taking place. Now, the conducting zone will include things like the nose, the pharynx, the trachea, bronchi, bronchioles, and the terminal bronchioles. Now, do we have gas exchange in these areas? And the answer is no. This is just the pathway to get air to the important gas exchange areas. Now, this will be referred to as an anatomic dead space because it's not grabbing any oxygen from the air and putting it into the blood. But it does act to filter the air, to warm it up, and to humidify that air as well. Now, the other zone is called the respiratory zone, and obviously this is the area of gas exchange. Now, it includes the alveoli, the alveolar ducts, and the respiratory bronchioles. Now, if you have any pathology in the respiratory zone, then you may get another type of dead space. Now, recall that we just called the conducting zone that anatomic dead space. That sounds bad, but every normal lung is going to have anatomical dead space. Now, if you get pathology in the respiratory zone, then that area has impaired gas exchange and it produces, again, another dead space. Therefore, that area of pathology plus your anatomic dead space is going to be your physiologic dead space, and we'll talk about later on in other lectures. Let's move on to some more lung anatomy. So hopefully you didn't forget all of your lung anatomy from first year. The right lung has 3 lobes, the left has 2 lobes and the lingula. Now, one very important fact to know is that the right lung is the more common side for an inhaled or an aspirated foreign body, because the right main stem bronchus is wider and more vertical than the left one. So the common test question is a 2-year-old who swallows or aspirates a coin, and then they say, where is the coin going to lodge? And the answer is going to be right main stem bronchus. The same scenario can actually happen with aspiration pneumonia as well. They can ask you which side of the aspiration pneumonia is more likely to occur. Now, each of the tertiary bronchi serves a specific bronchopulmonary segment. Now, these segments have each of their own artery. Thus, each bronchopulmonary segment is supplied by a bronchus and then 2 arteries, a pulmonary artery and a bronchial artery, which run together through the center of the segment. Veins and lymphatics are actually going to drain along the edges. Now, there are 10 bronchopulmonary segments in the right lung, so they have 3 in the superior lobe, 2 in the middle lobe, 5 in the inferior lobe, and then 8 to 10 segments on the left, so 4 to 5 in the upper lobe, 4 to 5 in the lower lobe. Now, each segment is separated from the others by a layer of connective tissue. Now, this is important because this means that each bronchopulmonary segment is a discrete anatomical and functional unit. And this separation means that a bronchopulmonary segment can be surgically removed without affecting the function of the other segments. Very important. Now let's talk about some pneumocytes. So pneumocytes are the cells that line the alveoli and are responsible for gas exchange. And there are 2 types of pneumocytes. Type 1 pneumocytes are simple squamous epithelial cells, and they comprise greater than 97% of the alveolar surface. Now, on light microscopy, they look very flat, simple, and they make up sort of the walls of the alveoli. Now, they are critical to gas exchange. Type 1 pneumocytes, however, are unable to replicate and are very susceptible to toxic insults. Now, what about our type 2 pneumocytes? So type 2 pneumocytes are larger, they're more cuboidal in shape, and they are more typically found at the alveolar septal junction. And they only cover about 3% of the alveolar surface. Now, their primary purpose is to secrete pulmonary surfactant. Its name is dipalmitoyl phosphatidylcholine. So surfactant, which is easier to say, acts to decrease alveolar surface tension. Now, this allows the lungs to be more compliant and to prevent atelectasis. Type 2 pneumocytes are also important during lung damage. Recall how those type 1 cells don't replicate. With lung damage, the type 2 cells can replicate, and they can even replace type 1 cells, or in some cases, they can even differentiate back into a type 1 cell. You should also be aware of the lecithin to sphingomyelin ratio. So this comes into play when we have premature labor or some other complication during pregnancy which would result in the delivery of a premature infant. So we take a sample of amniotic fluid, and the ratio is used to determine the lung maturity of those premature fetuses. So a ratio of greater than 2.0 in amniotic fluid will indicate fetal lung maturity. So again, if you have a situation where a baby needs to be delivered prematurely, like preeclampsia, gestational diabetes, or other complication, you'd want to know if the baby's lungs are mature. So babies tend to have a great deal more problems if they're delivered with immature lungs. So if the value is less than 2.0, then the baby's lungs are not mature because those type 2 pneumocytes aren't making enough of that surfactant, the dipalmitoyl phosphatidylcholine. Now, what can you give the mom to mature the baby's lungs? Well, you would give the mom corticosteroids, and that's actually going to help to mature the type 2 pneumocytes. Now, we're going to talk about steroids and how they prevent the neonatal respiratory distress syndrome in another video. All right, guys, that brings us to the end of the lecture part. It's time for that end of session quiz. Let's go through that together. First question, what structures traverse the diaphragm and at what vertebral level do they pass through? So remember, we got that great mnemonic, I ate 10 eggs at 12. So I8 is the inferior vena cava passing through at T8. The 10 eggs is going to refer to at T10, you're going to see your esophagus and the vagus nerve. And then at 12, the T12, you're going to see your aorta, your thoracic duct, and also your azygos vein. Next question, what histological change takes place in the trachea of a smoker? So remember, this is our famous metaplasia. More specifically, the ciliated columnar epithelium of the trachea is going to become squamous. So columnar is going to squamous, and then, as you can recall, you can't have that cilia moving stuff out, so you get a lot of mucus just hanging out in the trachea. Next question, what cell type proliferates during lung damage? Remember, the type 1 pneumocytes are kind of wimpy. They die, they can't come back, but the type 2 can. So type pneumocytes are going to differentiate, they're going to grow. Next, what amniotic fluid measurement is indicative of fetal lung maturity? So remember, your lecithin to sphingomyelin ratio, if it's greater than 2.0, you're doing pretty good. Next, a young woman has infertility, recurrent URIs, and dextrocardia. Which of her proteins is defective? So this is likely our Cartaginer syndrome, and here you would have the non-functional ciliated cells because the cilia can't move. Now the reason they can't move is because of dynein. So dynein is non-functional, and this is the dynein arm defect. And that dynein, again, is responsible for walking along microtubules. If they can't do that, then that cilia can't bend and move in particular directions. All right, guys, that brings us to the end of session quiz. We have one rapid fire fact. Same thing that we just talked about. Chronic sinusitis, infertility, situs inversus. Think of Cartaginer syndrome. All right, that brings us to the end of our lecture. I hope you learned something. I'll see you next time.